Thank you for those online for being here today. My colleagues, Dr. Guillaume Fontaine and Dr. Sonia Semenik and myself are planning a series on implementation science. And this is our first research seminar on this topic. We decided on this topic for the next year because we do have a critical mass of implementation scholars at the school. And nursing has a long-standing history also in terms of evidence-based practice. So it reaches all of our faculty members. So without further ado, it is my absolute pleasure and honor to be introducing Dr. Jeremy Grimshaw for our inaugural research seminar. So Dr. Jeremy Grimshaw received an MBChB, which is an MD equivalent, from the University of Edinburgh in the UK. He trained as a family physician prior to undertaking a PhD in health services research at the University of Aberdeen. He moved to Canada in 2002. His research focuses on the evaluation of interventions to disseminate and implement evidence-based practices. Dr. Grimshaw is a senior scientist, Clinical Epidemiology Program at Ottawa Hospital Research Institute. He's a full professor in the Department of Medicine at the University of Ottawa, and he held a Tier 1 Canada Research Chair for 20 years in health knowledge transfer and uptake. He is a fellow of the Canadian Academy of Health Sciences and a corresponding fellow of the Royal College of Edinburgh. He has been awarded the CIHR Knowledge Translation Award twice and received the 2018 CIHR Bear-Flood Career Achievement Award for Health Services and Policy Research. He has over 700, my apologies, 700, and I was getting too excited, 717 peer-reviewed publications, that's all. During the COVID-19 pandemic, he co-led the COVID End, which was a time-limited network to support COVID-19 evidence-based decision-making. He's also the co-lead of the Global Commission on Evidence to address societal challenges. So please join me in welcoming Dr. Grimshaw. Thank you.
Yeah. Can we get back to the slide deck on here? Because it's currently showing Zoom. I think I'd probably this one.
Correct.
Okay, good. So I'm delighted to be here. And I have a great and very gentle-looking audience in the room, and then we have a lot of people online, which, given I don't know who's there, is always a bit daunting. Just to, Sylvia's already said this. Hold on. This is sort of basically my personal journey. I've had the privilege of working full-time in research for almost 35 years. Through various ways I've been able to manage that. And so when, in terms of productivity and other stuff, that's at least one explanation of that, because I've not had to have a lot of the other roles that sort of academics have. I'm now planning for the next phase of my life. And when you get to this stage, it sort of makes you reflect on the career and what's happened. Have we made a difference in the world? And so you're going to get, this is like psychotherapy for me, okay? You're going to get sort of my view about how the field has developed over 35 years, whether it is whether we have done good or are we still missing. So the key question is implementation science class half full or half empty? And my initial answer is yes. So Schrodinger's implementation science class. It can be both half full and half empty. But I've often been in the last few years the sort of grumpy old guy. And one of the things that's kind of quite hard as you go through your career is you forget what it was like when you started. You forget what the backdrop was. I started my PhD in 1989. And basically, what I want to do is say what I think have been real, genuine advances over that period of time many of which we now just take for granted, many of which we don't realize that it wasn't like this, largely before probably some of you were born. So the glass is half full, we've made substantial progress. And I've got, I think, 10 sort of areas that I think we've made substantial progress in. So the first is we actually just recognize the problem. When I started, there was really very little discussion about, kind of quality or evidence-based practice. So we've actually sort of now, I think, got a very consistent body of evidence. And around the world, we know that 30 to 40% of patients don't get treatments of proven effectiveness, and 20 to 25% of patients get care that is not needed or is potentially harmful. And these are the two recent sort of publications. One was a large national study in Australia, published in MJA, and the CIHR paper was published by Janet Squires, one of my colleagues. They basically did an overview of all studies in Canada that looked at appropriateness, both overuse and underuse, and Canadian data exactly the same as the world. Okay, but we didn't know that before. But one of the things we also know is that there's no place in the world that's got this right. You can't go to anywhere in the world and say, oh, they're getting this right. Virtually every healthcare system has this. If you go to Kaiser Permanente, that many of us would see as a high-performing system, they would say, we're still struggling with this stuff. The VA has invested hugely in implementation science over the last sort of 20 years. They are still struggling with this stuff. And the fact that no one's got it right, I think, suggests this is just a fundamental challenge for healthcare systems. It's hard. We shouldn't be surprised, but we need to sort of try and actively address it. And I think at a policy level, kind of improving evidence-based practice is now a central tenet of most healthcare systems. It would be very hard to sort of think about a discussion about healthcare without people talking about wanting to promote evidence-based practice, etc. It's embedded into the IHI for quality sort of domains. So this is a genuine step forward. If we don't recognize a problem, we're not going to do anything about it. We now have recognized the problem, and both at a policy level and a research level, people are interested in engaging with it. Great step forward. The next thing that I suggest we have is taming the evidence base. So I started my PhD in 1989. At that point in time, my guess would be that there were probably less than 200 systematic reviews out there. The term was not widely used. I was introduced to it in 1994 at a BMJ conference when 1992 or 3, where we worked out that I'd been doing a systematic review, it's just I didn't know what it was. So we really didn't have that. Cochrane did not exist. The prototype of Cochrane, Effective Care and Practices of Pregnancy and Childbirth, did. And think about where we are now. If anything, now we have too many systematic reviews. We've got a lot of inappropriate duplication of effort, but it is now a lot easier to start to try and identify authoritative summaries of evidence about what we should be trying to achieve. And we've also broadened out the sort of those methods so they now apply across every type of knowledge base. So it's not just systematic reviews of effectiveness studies. We can actually look across any sort of research. And we also have made huge progress on guidelines. So again, 1989, there weren't that many guidelines out there. They were largely professional consensus guidelines where good old boys sat around the table would sort of come together and say, oh, we think that the world should do this. And that's no longer acceptable. We now have rigorous approaches to trying to develop guidelines. And in a number of countries, not Canada at a national level and not Canada in most provinces, there are investments to try and provide jurisdictional advice to healthcare systems and healthcare professionals. And Guidelines International, the Guidelines International Network is what it sounds like. It's an international network of guideline producers that are working together to promote the idea of concept of guidelines, but also methods and approaches around that. And if you're interested in the guideline space, getting to know Jim is kind of, I think, very useful. So that's, again, really good progress. When I started, I had to go physically to my library. I had to use either a CD-ROM version or a paper version of Index Medicus. And it was kind of really, and I had to hand search journals. It was kind of quite a different time. I think the third, and this is probably most important, is we can study how to improve care. Everyone knows this slide. Everyone has seen this. But if you go back, the view was something like, well, we can't do anything because things just happen and that's it. And basically, I think over this period of time, we said, no, actually, this is something, implementation is a human enterprise. This is something that we can study. And we can study so we understand the processes and think about how could we improve things in the future to increase the likelihood that our implementation efforts lead to improvements. When I did my PhD in the Health Services Research Unit in Aberdeen, and I worked there for 13 years. The Health Services Research Unit was funded by the government in Scotland, and its mandate we had to work for the implementation of proven therapies or whatever. And we had a very, I think, interesting debate in the early 90s. But basically, what could we do? Well, if we did a piece of research and we found that something looked like it was kind of beneficial, maybe what we could do if we wanted to try and promote implementation, we could send that researcher and just put them on a bus and send them around Scotland, and they could just go around for the next 3 years, and who knows, maybe something would happen. A number of issues with that. One is it's actually not a good use of the researcher's time. Secondly, the researchers are often not the right people to actually go and engage with colleagues in the healthcare system. And also as researchers, we love our babies, so we don't see the flaws. And so again, we tend to, we always are much more positive about where we've got to within that. And so we, as a unit, said, well, what we can do though is we could study the process. And that led to us sort of basically moving this forward. In 2006, Implementation Science was founded, and this was the lead editorial by Martin Eccles and Brian Mittman. The scientific, which defines implementation science as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. I'm not sure it's a great definition, but it's okay. But actually having something was fine, because then you can say, well, this is what it is, this is what we're trying to do. So I'm sure I've got lots of grants where somewhere that phrase goes in, because certainly in the early days, again, going to peer reviews, I had no idea what on earth we're doing. And this is just a plug, but in 1998, we actually applied and got funding from the University of Aberdeen to establish the Centre for Implementation Research. Terminology was still sort of pretty nascent at that time, but we persuaded the University of Aberdeen that we should invest in this, and it built on, at that time, I guess, 9 years of work. But we're starting to get sort of recognition that this is both a legitimate area of research, an important area of research, and one where certainly in Aberdeen at the time we had expertise. So we can study how to improve care, and many different types of research are needed. A lot of what I've done is focused on effectiveness, but actually we need a plethora of different types of research, and that's a whole different talk. But this is, there are lots of ways in which we actually, lenses we have to apply if we want to make sense in this area. So the next, I think, the next sort of insight is it is possible to change practice and improve healthcare. This is a phrase that got into my head, but this was a kind of view about what things were like in the 1980s. Just an impossible problem, you can't do it. You'll have to wait for doctors to retire or die to change their practice. I'm aware that I'm in a faculty of nursing, but I think you can also put nurses in there as well, or physios or OTs for Brigitte Vachon in the audience. Sort of basically, people just get stuck in their ways and you can't get them out of it. So the systematic review, the first systematic review I did got published in The Lancet in 1993. And this had started off as work for a book chapter that was sort of looking at referral guidelines. And I was working with my PhD supervisor, Ian Russell, and he had been doing work in the kind of quality space for at least a decade. And we were really interested because he could probably identify 4 or 5 studies. And, basically, this is what happens when you do a systematic review. You just worry at it and you keep worrying and you go back to the library and you search more CD-ROMs with different terms. And we found that there were 61 studies that we could identify that were about trying to disseminate or implement practice guidelines published by 1992, which was way more than anyone else thought. 59 out of those 61 showed improvements in the process of care, and 11 studies looking at outcome of care, 9 out of 11 showed improvements in outcome. And so suddenly that idea that you have to wait for people to die or retire is just false. There are lots of examples from around the world demonstrating this could be done. Doesn't mean it's easy, doesn't mean there's easy answers, but actually, healthcare systems and healthcare professionals will change if supported. It's not a surprise to healthcare professionals because we want to do the right thing for our patients. And if you make it easier for us to do that, or you help us understand what we should do, that's great. But it actually was, again, a very helpful, I think, step forward for that. And we actually have now probably tens of thousands of evaluative studies looking at interventions to improve care. And these are just summaries from Cochrane or Cochrane-related reviews, because the latest Quad one wasn't published at Cochrane. But Noah Ivers from Toronto did the audit feedback review in 2012. There were 140 trials. The median effect that we saw was a 4% improvement in absolute terms, with an interquartile range of 1 to 16%. And really, that's kind of what we see. In general, the median effects are 4 to 8%, in the median slightly higher, but you've got this large variation. And I think what it tells us is that in general, audit feedback works. But we don't know when we should use it, how we should use it, how we optimize it, so we get closer to the 16% rather than the 1%. But we have large bodies of evidence that we can build upon that are there. NOAA is just about to submit the update of audit feedback. So by 2023, there are now 299 trials of audit feedback. We have large bodies of evidence. Imagine another area of healthcare where you had 299 trials. You'd think that we actually know everything about that area. You'd have stopped doing the trials after probably 10. I think that's also, which will come back in some of the issues.
Go to friends in England, which I achieved. I went to England.
Yeah.
Could you
I think
mute,
let's recycle them. We have limited shelf space.
if you're online, could you mute, please? We just broadcast to the whole conference. Thank you. Okay, so
Oh, thanks.
no problem.
Also, I'm making a pot of the
Yeah,
almond
so
green tea.
just mute. You should be able to mute all if you, whoever's the. Okay, I'll keep
Done.
going.
It's done.
Okay, we're done. Good. Sorry about that for people. And this was a paper that Andy Oxon published in CMAJ in 1996 called No Magic Bullets. And our knowledge base hasn't changed. All of the things that we do to try and improve care, sometimes they work. And none of them work all of the time. It's unclear when they do work whether they maximally improve practice. And it's also unclear when they do work whether they represent the most efficient use of scarce healthcare quality improvement resources. And that remains, I think, one of the central challenges of this. Healthcare systems have limited resources, healthcare professionals and teams have limited bandwidth. How do we get the maximal improvements within the realities of those constraints? Number 5. Again, if I go back to the 1990s, the assumption was that evidence-based gaps are just due to knowledge gaps. So most of the approaches were, well, we just have to give people more knowledge. So interventions tended to focus on knowledge provision education. We have shown time and time and time again that knowledge is rarely the barrier. Healthcare professionals either have the knowledge or good enough knowledge. They may not know all the fine detail or the sort of the latest targets of hypertension control, but we're actually not managing to improve yet back to targets from 2 times ago in hypertension control. Knowledge is very rarely, unless you're working very emergent space, the problem. So with Guillaume, we're working in hepatitis C, and one of our colleagues is looking at hepatitis C treatment in primary care. And there are genuine knowledge gaps there, because the new drugs have come out after the general practitioners went into practice. It's come out of specialist practice. And so there's some genuine issues there where there truly will be knowledge. But in many cases, I left medical school in 1984. We knew we should screen diabetic patients or people with diabetes eyes. That's not a knowledge issue. Maybe a skill issue, maybe an organizational issue. But there were, even in the early days, some just insight which were really helpful. So this is a single author paper from the New England Journal of Medicine in 1976 by someone called Clem MacDonald, who worked at the Regenstrief Institute. And he was at the absolute cutting edge of computerized systems in healthcare. And they developed an in-house system in Regenstrief that was not used in the consultation, but clinicians filled out a consultation sheet. It was entered into the computer. But they then programmed the computer to actually sort of say, hey, remember next time you need to do the blood pressure or something else. But what I like about this paper, I mean, the title's good. Got to confess, the non-perfectibility of man, it makes you kind of think, okay, what's that? Yeah, because I'm hope to be a professor. I'll be perfect. But if you just read this, it actually is just worthwhile reading. Implicit in the currently available remedies for medical errors is the belief that man is perfectible, and his errors can be limited by training or coercion. However, man is not perfectible. Sorry, I cut it off, but there are limits to man's capabilities about information processing. And Clem MacDonald was pointing out in 1976 what cognitive psychologists would say bounded rationality. The human brain is not a supercomputer. You know, there are a range of things that we do. We create habits and heuristics to get through the day, but they often, when they become ingrained in practice, become sources of error or are hard to change if you then want to try and change someone's habitual behavior because new evidence has emerged. So 1976, pretty good. He also published a more discussion paper on heuristics in JAMA in the early 80s. Another example, I mentioned Brian Mittman, who's one of the founding editors of Implementation Science, but this was the first paper that I came across of his, which was basically a paper in the Quarterly Review Bulletin that largely sort of was arguing that insights from social psychology could be used to think about professional behavior change. So Brian was a social psychologist, that's where he came from. And this is, again, just a different discussion point or discussion paper, but it's like someone opened a door, said, hey, other people are thinking about this in ways that might be helpful. And it was actually, for me, quite a profound sort of, oh my goodness. So I thank Brian for that. We have moved on. So this was a paper that Martin Eccles and I led in 2005, where we argued that up until that time, in general, a lot of implementation approaches had been atheoretical. They'd been kind of common sense guesswork, which sometimes worked, sometimes didn't work. But some of the challenges were that you often, because you didn't understand what the hypotheses were about the mechanisms of action and what might be effect modifiers, it made it very hard to know, well, could this be transferable? Or how you might interpret a negative study as that worked through. So we argued that we need to better use extant theory to inform what we do, and also to explore mechanisms of action when we are actually trying to evaluate. Again, you can see it's called a variance of descent and descent. The editors got a number of our really good friends and colleagues, so Andy Oxman, Attila Freitime, Signe Flotter, and they then they basically sort of said, put a short paper up saying, "You're wrong, we hate this." And basically, one of the interesting things is that they were using theory from the kind of, the paper actually has quotes from Yogi Berra, the baseball player, which sort of would all be about, theory is a kind of, your idea that is sort of just stupid. So it's not actually, this is a theory that is based on an empirical study and has been thought that's just on a Friday night in the bar. Well, that's your theory. And we got the chance to respond to them. And they got the chance to respond to us. It's a kind of fun string if you want to look at that. But we're now in a, again, much better position. So this is the theoretical domains work that was developed by Susan Michi, and this sort of tried to synthesize knowledge in psychology, across psychology, to identify what are the key domains that actually influence our behaviors, and they identified 14 different domains. And this is this can be used as a checklist. So if you're doing qualitative work, you can very quickly go through all of these things, and if you're just doing them all sort of grounded, we'll see where it goes to. Maybe things get dropped off because you just don't get around to them. The other thing is that other work that Susan has done helps us recognize that if you want to change knowledge, you should do different things than if you want to change beliefs about capabilities or beliefs about social, professional role and identity. So it helps us start to think at a different level about, well, what is it? If the fundamental issue is that we did a study looking at trying to improve epilepsy care in primary care in Scotland, but the fundamental issue, nothing worked, was that family doctors thought epilepsy is a specialty care thing in the 1990s. And so, even though we kind of tried to give them support, whatever, just on my job, and I've got enough to do. We've got all those specialists who can do it. So this has been, I think, a very helpful move forward. Next, we are, in brackets, hopefully, better at designing implementation programs. So Martin Eccles, at some point in time, basically reflecting on his time of being in rooms where people discuss the implementation strategies, suggested in most cases it used the ISGLIAC principle. And basically that is, it seemed like a good idea at the time. You will get rooms of often very senior healthcare professionals who will come into a room and sort of basically have a conversation, and somehow, like the election of a pope, a puff of smoke appears, and this is what we're going to do. And it's often, who's talked loudest, who's talked longest, who's got a Y chromosome, who's got less hair, more white hair. It's the kind of, again, the good old boys sat around the table. And to be fair, sometimes when we do that, people get it right. So it's not saying, there's a lot of tacit knowledge that healthcare professionals have, but they often, two things. One is there's also a lot of external knowledge that could be helpful, but it's often not brought in. And the second thing is that often people aren't really being very systematic or pointed about, well, why do we think that is going to work? I spend a lot of my time where people say, we've got to do this. And I say, that makes me think that you think the main problem is this. Is that what you think? And is that the only barrier? What about, and I can normally identify 3 things that wouldn't be solved by what we've got, that sort of, well, we may have to think about that as well. So hopefully we're getting better at this. A colleague, Simon French, produced a very simple process, a 4-step process, taking a very behavioral perspective, identify who needs to do what differently, identify what barriers determine current practices and barriers and facilitators to desired practices, then think about what strategies can be effectively used to target those factors, and how can we robustly measure the outcome. It's a very simple framework. When we talk to people in the healthcare system, I would say, I commonly say, in general, in healthcare systems, we jump to three. We jump to the solution without thinking about the problem. And in general, people rub their heads and they get that, and this is our experience. So we're doing better. And you know, this is improving all the time. We're seeing increasing use of end user engagement, co-creation, user-centered design. You know, we're getting a lot more sophisticated as we move forward in terms of trying to design interventions. We have to test whether these things actually make a difference. But we are, I think, thinking very much about that. I'm going to move quite quickly. I've already really mentioned this, but certainly from my program, we've seen the problem of implementations of one of changing people's behaviors who are living and working in complex environments. Those people might be patients, healthcare professionals, managers, policymakers. But when you start to say this is a behavioral change problem and a system problem, again, it brings different lenses to bear, which can be helpful. This should not be underestimated. Research funding has been established. Basically for the first 10 years of my career, I'd be sort of looking to see, well, how do I make this sound like it's an MRC grant? How do I make this sound like it's a Chief Scientist Office grant? In 1997, the UK NHS R&D program had, I think, probably the first program in the world that was specific on implementation science, on the evaluation of methods to promote the implementation of health research. They did 2 rounds, and it lasted about 5 years. And whilst that was a real step forward, and I think helped with the community in the UK, this isn't a problem that we're going to solve by having a 5-year program of research. This is going to be a problem that is ongoing in healthcare systems. If you ever get to the stage where we know how to do this, that would be wonderful. But I don't think it's going to happen in any of your lifetimes. The NIH, I think, deserves very sort of specific credit here. In 2005, I think through the NCI Institute, they established a special emphasis panel. So this is like, we want to have a peer review panel that will look at implementation science. The special emphasis means it's like, it's a prototype. We'll see what happens, see if it's going to stick. But in 2010, they then created a standard panel. And by now, last night, one of my colleagues in the NIH said they've had something like 423 awards over this period of time. This, again, just really was important in the US. It told US colleagues, hey, this is really important. The NIH recognized it, but globally, it was really important. The NIH, as one of the world's leading funders, is saying this is something we need to do. In Canada, it's been a bit up and down. CIHR, when it's founded, had knowledge translation as a mandate. I don't think, with due respect to my colleagues at CIHR, that they necessarily knew what that meant over a period of time. There's a period of time in the 2010s when Ian Graham went to become the VP of KT at CIHR, and CIHR became known globally as a funder that had very innovative programs. Unfortunately, most of those got killed off. But we do now have a knowledge translation research peer review panel. So there again, it is better now than it was, basically 20 years ago. And the final thing, and I'm not really going to spend much time, but there is now a community globally. So I was at the first NIH D&I conference, which was held in a lecture room in NIH, and there were probably about 200 participants. And most of them were sort of NIH staffers. Last year, in the 16th annual conference, there were over 1,300 participants. And that was a bit down because of the pandemic. They're still recovering. But it's quite remarkable what you've got. We have amazing training programs. Again, I'd say particularly NIH funded in the US, but they have actually metastasized. So one of the programs is now running in Australia by colleagues there. One of the programs is now running in Ireland by folks there. And these programs are also available for non-Americans. So a number of my trainees have gone to take them, and they're really, really good. And in the US, we're getting kind of either academic departments or specializations in departments. Not in Canada. We're very conservative academia, which I think is a bit frustrating. So, but lots to celebrate. I think if you'd have asked me 35 years ago, I'd have hoped we'd have solved it by now. But that was because I was naive, didn't really understand it. But we've actually made lots of approaches. But then I have those days when the glass is half empty. We've made no substantial progress, but we've made lots of noise. As I tell people I'm retiring, lots of people say, oh, you've made such a contribution. But in reality, if I look back and I'm very, very hard-nosed about it, we've not really shifted the needle. That's okay, we've done a lot of stuff. I think we're making progress, but we're a long way from where we need to be. And yeah, the comments I have here coming after this will reflect what I think implementation science is about. So I think implementation science is an applied science which is trying to generate practical insights and tools that will support healthcare systems and healthcare professionals to increase the likelihood that their implementation efforts are more successful. That's the goal. And I think, the question is, are we getting there? I recently gave a presentation at a Swiss meeting, and kind of presentation went well, seemed to be well received. And then I had 2 questions from Swiss professors, and they were great questions. And they're kind of a bit, I thought it was benign, it's like, oh my goodness, okay, these are hard questions. So one was, do you think it's made any difference? And that was from a professor of implementation science. And that's, it's very hard for me to sort of point to anything like we've made a substantive difference. Lots of little things, but And then another, I don't know, it might have been a professional clinician, but again, a great comment, which was when I discuss quality improvement approaches, I just said, get it. Yeah, okay, we'll do that. When I start talking implementation science, they glaze over. We're introducing new ideas and concepts to them using language, which is often arcane, and they're kind of like, I'm sorry, I have no idea what you talk about. So I think the danger is that we've made a lot of noise. We have failed to build a shared understanding of language for the core concepts about implementation terms, and failure to do so is limiting scientific progress. I've not changed this slide for 10 years. Different terms are used to express the same concepts. The same term is used to express different concepts. Many concepts are poorly described and defined. If we are talking across each other about different things or the same things, then we're not going to advance things. I actually think this is insurmountable, partly because implementation science brings lots of disciplines together and they have different languages or perspectives, but we need to find a way of improving things. We need a Rosetta Stone that will help us do that. I've not changed this slide for 10 years. I gave the keynote at the first NIH Dissemination Implementation Conference, and I argued we needed more theory, but also there is a danger that there are too many theories and not enough theory. So there are a profusion of theories that are often poorly conceptualized, rarely operationalized, and even more rarely tested. And that means they're just noise. They are kind of basically Yogi Berra's view. Well, that's sort of Guillaume Fontaine in the bar on a Friday. He scribbled down a model, and it's going to be the Fontaine model. He'll publish it. No one will ever cite it, but it's a Fontaine model, therefore, and it'll be very good when he goes for promotion. I was the founder of the Fontaine model. I think we need predictive theories that can incrementally improve the likelihood of successful implementation, and we need rigorous evaluation of candidate theories. And this is a very serious but provocative statement. Should we ban theory development until we've tested currently available theories? Imagine. And when we test theories, we may find that they don't work. And that's a really good thing. So Robert West is one of the leading sort of health psychologists, done a huge amount of work in addiction. And he published this discussion paper in 2005, where he basically said, we need to just retire, kill off the trans-theoretical stages of change model. So there may be people in the room who love that, I apologize. But this is the model that says, well, we go from people when they change behavior, go from pre-contemplative to contemplative to planning to change to consolidation or whatever. I may not have got the language quite right, but we go through this stages process. And Robert basically takes this apart. Worthwhile reading. It says there are serious problems with the model. it's not coherent. Some people go from pre-contemplative to just done. They don't go through these phases, which the model sort of says, well, we should go through this in a very sequential, logical way to do that. Some of the ways it's been operationalized don't particularly make sense. Yeah, we should do this if you're contemplative, but this if you're the planning. And it's not quite clear whether that makes sense. But also, more importantly, if you looked at systematic reviews that have looked at interventions based on stages change theories, they're no more effective than other theoretical models. They're actually no more effective than sort of basically just the common sense, whatever. And so, Robert's comment was, this has got such a hold. It's got great face validity, but it's got such a hold. It's actually limiting conversations about, well, what can we learn from that? So I think there's a lot we can learn from this, but we have to realize that it is at best incomplete and at worst not particularly helpful. If you go back to this paper, there are then a series of 10 responses, including from Prochaska. And it's great because half of them are like, yeah, we should kill it. And half of them are like, no, you're really wrong. But this is how we advance science. We put theories up, we should test them. They should be testable. And if they work, great. If they don't work, we should be honest. And we've learned something. It looks like a very sort of passed out theoretical or changes to state model probably isn't particularly helpful at this point in time. But at a minimum, there seems to be a step between pre-intention and an action. So just because we intend, we won't do something. So it's not that the model is completely bankrupt, but we can learn from it if we are critical, rather than if we just develop the Grimshaw status change model, which will be perfect. Some of the issues here is it's challenging for non-implementation scientists to make sense of this cacophony. And also, if I was a manager and I got 3 implementation scientists in the room and asked them what to do, I'd get 4 different ideas. And most of them would be about what I want to do in my research, not kind of this is what we know. So I do worry that we are building an academic implementation research community that is internal looking and internal communicating, and it's not serving the broader interests of the healthcare system. And I think we have to seriously take that and work out how to do that. We pursue the shiny new object and do not build implementation science cumulative. So a normative view of science is that it is curative. It builds upon previous knowledge and is self-correcting. One of the challenges is our academic incentives are for novelty, for innovation. And replication and cumulative develop is not particularly seen as sexy or fundable. This is a problem in Canada. It's a big problem in the NIH. And it leads to people pursuing shiny new objects. People always want to find, social media will solve the world on this. And then, we kind of work out, not particularly vigorously, but, 2 years later, that it might be part of the solution, but it's not the solution. So we pursue shiny new objects and make them seem really, 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 really complex. So you need to hire me to help you with this with long labels. And one thing to recognize, most of those trials of ordinate feedback that demonstrated ordinate feedback led to improvements did not have a complex theoretical underpinning, and we have to do a barrier assessment, and we have to do something else. People just did it, and they could improve care. And so I think, what we should be doing is saying, well, our base block is this sort of what we've learned through a lot of sort of, probably hit and miss and theoretical work. But now we're trying to build science to see if we can enhance that. Can we use implementation science methods that will to help us understand how we can improve the effectiveness of ordinate feedback, rather than sort of doing something completely new and whizzy? So I think we should build on these and determine whether implementation science approaches will improve them. Kind of worried about time. I'm kind of 8 slides left.
We're good.
Okay, but there's a couple of really good stories. This is a lovely paper about what happens when you go after the shiny object, and it talks about quality improvement. And Kieran Walsh is a professor of health, probably health systems. I'm not sure, health systems policy, kind of management perspective from Manchester. And he did this lovely study that was published in 2009 that he just wanted to look to see how in the published literature different quality approaches were cited. So I just said, okay, well, let's look to see how many studies have cited medical audit, how many studies have cited Six Sigma, Lean Six Sigma, and this is what he found. And what you see is that there are waves. So in the early 1990s, there was a lot of emphasis on medical audit. That dropped off by 93, 94. That was changed into, I think, clinical audit, and that dropped off. And then you could see clinical governance came through in the sort of late 1990s, early 2000s. And then later on from there, you had Lean Six Sigma, patient safety. And you just have these waves. Well, what Kieran noted is the repeated presentation of an essentially similar set of QI ideas and methods under different names and terminology is a process of pseudo-innovation. But there's probably more common in those approaches than differences, but we give them a new shiny object. And this is driven by both the incentives for QI methodology developers. It's very hard, like we're working for you for 10 years and we've made some progress. So let's just keep doing what we're doing, we'll be okay, as opposed to, and now I've got this new shiny tool, isn't it great? This is going to be great for me. And also the demands and expectations of those responsible for QI in healthcare. I'm sick of that medical audit stuff. Sure, you've got something else you can tell us. We argue this process has important disbenefits because QI programs need sustained and long-term investment and support in order to bring about significant improvements. The repeated redesign of QI programs may have damaged or limited their effectiveness in many healthcare organizations. And then goes on to be more skeptical and scientific, which approach would be too. But this is kind of this is where we are. And just to give you an example, and I'm a bit nervous about this because I'm going to be unfair to a couple of authors. Noah Ivers published the Audit and Feedback Review in 2012. There are 140 trials. So I apologize if people know this group. But in 2016, there was a paper in JAMA on physician peer comparisons as a non-financial strategy to improve value of care. This is great, it's a shiny new object. Basically audit and feedback. And the references mention nothing about the by that time, 20 to 30 year history. We wrote to JAMA and they didn't want to publish the paper, our reply. But we have this sort of pseudo innovation, and it's partly being driven by what will be funded, what we think will be good for our promotions. It's not being funded by the needs of the people who want to use implementation science to improve care. Very quickly, we are really failing to build informative science. Thousands of studies that provide flawed or limited information. If we look at trials, although people got much better about cluster randomization, we still have too small trials. Basically, I mean, if you look at the average effect we saw in the reviews, you're probably lucky if you should probably power your trials for about a 5% absolute improvement. Most people can get 20 hospitals, so that will mean that I can get a difference of 15%. So our sample size is 15% without any justification. And so you get underdone trials. A whole range of other sort of things. As a trialist, there's a lot of things we could do so much better around this. Here's just an example of that. Again, this was work that Noah Ivers did, which was based on the Cochrane Audit and Feedback Review. But this was just looking at the evolution of the knowledge on the effects of audit and feedback as more trials are added. So you can see that by 1994, there were 21 studies published. And by 2000, there had been another 77 studies published. But arguably, the effect size and the interquartile rate really hasn't changed much. You might argue that those 70 trials after 1994 largely didn't add to the knowledge base. We could have done a lot better. I sometimes call this the I-squared problem, the implementation science, but we don't implement implementation science. We're producing new findings that could contribute to effective research or effective implementation, but the findings of the research will not change evidence unless receptors in the healthcare systems adopt them in practice. And implementation research, I don't think to date have convinced healthcare systems of the utility of our approaches. It should be beating a drum to our door, but it's kind of like, you do what? And I have to do this sort of survey of my staff, and it's going to take me 12 months before I can sort of do anything. So I think we need to do much better. We need to find ways of increasing the signal to noise for healthcare systems stakeholders. I think if we could actually start to say, this is what we're pretty confident about. And here's all the stuff we're doing at the moment, which might help, which will actually help in the future. I think there's a really good argument that we should have audit and feedback as just a foundational support in healthcare systems for healthcare professionals. Healthcare professionals can't judge their own practice because it's often hard to observe what's going on. And we often will overestimate our performance because we're human beings. Audit and feedback can help. Why don't we think about that as being something that is just pretty standard? There's a subset of the audit and feedback review looking at audit and feedback for antimicrobial or reducing antibiotics in primary care settings that is under review. But basically, audit and feedback will reduce antibiotic use of broad antibiotics and length of antibiotics in primary care settings. Why, given we were trying to address AMR, why isn't every jurisdiction in Canada finding ways of giving family docs evidence about that? So I think we need to do that. And we probably have to more clearly articulate the difference between implementation practice and implementation science. We still want healthcare systems to work with us when we're doing innovative implementation science stuff, but we sort of really need to, I think, be kind of quite clear. Here's things you can do in the next 12 months that are likely to make a difference in your organization. So, is the implementation science glass half full or half empty? Yes. So, in summary, I think implementation science has achieved much in a short time scale. But I personally have some concerns about the current directions that appear to creating an internal academic dialogue within the community, which may not be meeting the needs of healthcare system partners. I am afraid that I have stopped responding to Delphi surveys about some little thing that is going out to other implementation scientists. Not how we advance science. We advance science by looking at the world, making sense of it, and trying to change the world. Knowing how I think and how Guillaume thinks and how other people think, we most likely are wrong. So we have to go out and look at the world and make sense of it. So we need to do better. I think implementation science is an amazing place to do work. Lots of opportunities for benefit. One of the things that's driven me is I think that if we get this right, the societal benefits will be huge. But we have to be constantly self-critical and rigorous. It's very easy to just, ease back into easy, not particularly interesting or informative science because I got that funded last time, so if I do it again, it will look okay. We constantly have to push and be rigorous and be self-critical. And that's why I'm retiring. So thank you very much. I'm happy if we have time for questions to take any questions.
Thank you so much for the